Welcome back to The Explainer. Today, we're tackling something incredibly vital, the landmark clinical trials that actually dictate how eye care professionals manage sight-threatening diseases. We aren't just reading off some dry list of medical studies here. We're treating these trials as an evidence-based playbook, a literal roadmap for saving a patient's vision. When a doctor sits across from a patient, they aren't just guessing. They're relying on decades of rigorous, peer-reviewed data. So today, we're going to unpack exactly what that data tells us and see how these high-stakes clinical decisions are actually made in the real world. Let's get into it. To make sense of all this complex medical data, we're going to follow a really logical progression today. We'll start with defining the glaucoma threat, then predicting who is at risk, move into the power of pressure, choosing the first defense, advanced surgical interventions, and finally, melanoma and optic neuritis.
All right, Section 1, defining the glaucoma threat, establishing the baseline.
Before making any clinical decisions, we really have to understand the enemy we're fighting, right? Our source material defines glaucoma as a group of ocular diseases ultimately associated with progressive optic neuropathy, leading to loss of visual function. The key word to zero in on here is progressive. If left unchecked, this neuropathy just marches forward, irreversibly taking a patient's vision.
Okay, let's dive right into Section 2, predicting who is at risk, the OHTS and LAILS data.
To catch these problems early, doctors rely heavily on the Ocular Hypertension Treatment Study, or the OHTS. This trial is huge because it identified specific, measurable risk factors for primary open-angle glaucoma. We're talking about factors like a patient's age, their vertical cup-to-disc ratio, and their central corneal thickness. These things drastically increase the percentage risk. So by measuring these specific physiological traits, doctors can pinpoint exactly who is in the most danger before the severe damage even occurs.
Look at how brilliantly the data visualizes this finding from the OHTS trial. Patients with a central corneal thickness of less than 556 micrometers carry a significantly higher risk of developing glaucoma than those with corneas thicker than 588 micrometers. Think about that for a second. A microscopic difference yields a massive predictive value for optic nerve damage down the line. It's just wild.
But hey, anatomy isn't the only predictor. Demographics are a huge piece of this puzzle too. The Los Angeles Latino Eye Study, LALES for short, found that Latinos who are 80 years and older are 15 times more likely to develop open-angle glaucoma than younger Latinos in their 40s. 15 times! That is a massive demographic takeaway, and it strongly illustrates exactly why age and ethnicity absolutely must dictate a doctor's vigilance in ongoing risk assessment. Moving right along to Section 3, the power of pressure, why IOP is the primary directive.
So this brings up a massive clinical dilemma that eye care professionals face literally every single day. When exactly should treatment begin? Do you just watch and wait to see if the patient actually starts losing their vision, or do you jump in immediately with preventative treatment? It's a huge question with very real stakes.
Well, the early manifest glaucoma trial gives us a definitive answer, 50%. Immediate IOP lowering treatment reduces the risk of progression by exactly half. 50% of the treatment group progressed compared to 62% in the observation group, and the time until progression was significantly delayed. The evidence is absolutely clear here. When in doubt, immediate intervention protects vision. And the Advanced Glaucoma Intervention Study, or AGIS, gave us a definitive target to aim for, under 18 millimeters of mercury. This trial proved that keeping intraocular pressure consistently below 18 virtually halts visual field loss over a 7-year period. If a doctor can keep that pressure strictly controlled under 18, the progressive vision loss is essentially stopped in its tracks. That's the power of pressure control. Now, in medicine, there's almost always an exception to the rule, right? And for glaucoma, that exception is found in the Collaborative Normal Tension Glaucoma Study, or CNTGS. What happens if the patient's pressure is already seemingly normal, but they still have glaucoma? The CNTGS trial actually guides doctors differently here. You monitor these patients without immediate treatment. You wait to see documented progression or the appearance of high-risk factors like a disc hemorrhage. Only then do you intervene, and your goal is a 30% reduction from their baseline pressure. It's a highly tailored wait-and-see strategy. Okay, Section 4, choosing the first defense, drops versus lasers. Once a patient clearly needs treatment, what's the first weapon drawn? The SLT trial directly challenges traditional thinking here. For the longest time, daily eye drops were just the default first step. But when compared directly against traditional medical therapy, selective laser trabeculoplasty showed equal efficacy in lowering IOP. This is a total game changer because it makes laser treatment a highly valid initial option, completely bypassing the very common issue of patients simply forgetting or struggling to take their daily eye drops. And if a doctor does choose drops, the ISIS trial gives us a masterclass in precision medicine. It found that for patients with a specific condition called exfoliation syndrome, outflow enhancers like latanoprost yield a 1.3 millimeter of mercury greater reduction in pressure than standard timolol drops. This perfectly highlights why your doctor needs to know your exact diagnosis. Specific variations of the disease require specifically targeted medications to get the best result. It's not one size fits all.
Section 5. Advanced Surgical Interventions. Bringing in the heavy artillery.
So what happens when those frontline drops and mild lasers fail? The CIGTS trial looked at newly diagnosed patients and asked a really critical question. Should we just go straight to conventional filtration surgery instead of starting with medical drops? Well, while the trial found that long-term visual field loss was similar between the two groups, patients who had immediate surgery faced way higher early surgical risks, like cataracts. Therefore, the evidence-based consensus remains pretty firm. Stick to conventional medical drops first for newly diagnosed patients before you rush them into the operating room.
But when surgery is eventually needed, the long-term data from the TVT trial offers some really vital guidance. After 5 years of follow-up, tube shunts actually showed a higher success rate and significantly fewer treatment failures compared to traditional trabeculectomies. This data is fascinating, and it's actively shifted clinical practice toward using tube shunts way more frequently.
Then we have the EAGLE trial, which focused on a totally different type of the disease, primary angle closure glaucoma. They compared a procedure called clear lens extraction against a standard laser procedure called LPI. The conclusion here was absolutely definitive. Extracting the clear lens offered patients a superior overall health status and achieved a lower intraocular pressure than the laser alone. So sometimes completely removing the eye's natural lens is just the best anatomical fix.
Finally, Section 6. Melanoma and optic neuritis beyond glaucoma.
Now we are pivoting entirely. Unlike glaucoma is incredibly slow progression, optic neuritis is an inflammatory, infective, or demyelinating process that causes a sudden, acute attack on the optic nerve. And the way you treat it is fascinatingly counterintuitive.
The Optic Neuritis Treatment Trial, the ONT, gave us a very specific step-by-step protocol. Step 1, intravenous steroids for 3 days. Step 2, oral steroids for 11 days. Now, you might be wondering, why not just give them the oral pills from the start and avoid the whole IV process? Well, the trial found that prescribing oral prednisone alone actually increased the rate of future bouts of optic neuritis. Crazy, right? By following this strict IV to oral step process, doctors can safely accelerate visual recovery without putting the patient at a higher risk of relapse down the road. Lastly, we look at the Collaborative Ocular Melanoma Study, or COMS. For patients with a medium-sized tumor in the eye, the trial compared enucleation, which is removing the eye, against eye-sparing brachytherapy. The incredibly reassuring takeaway here is that the survival rates are practically identical. A patient can opt for eye-sparing radiation therapy without compromising their chance of survival whatsoever.
And that brings us to the end of our clinical journey today. We've seen how decades of evidence dictate literally everything, from assessing the thickness of a cornea to timing an IV steroid. But as we've seen today, the playbook is always evolving. With advanced surgeries and laser therapies increasingly rivaling traditional eye drops as a true first-line defense, I want to leave you with this thought. How will the next decade of data further redefine vision preservation? Science never sleeps, and the evidence-based playbook is only going to get better. Thanks for exploring this with me today on The Explainer. Keep learning, keep asking questions, and I'll catch you next time.